I invite Dr. Rishikesh to talk to us about pharmacological interventions. So, I mean, all said and done, the optical intervention is expensive. So that's where in cost side, the atropine holds good.
Thank you. At the outset, I would like to thank the scientific committee AIOS and NTOD for this wonderful, it is indeed a privilege to be a part of this August gathering of people interested in myopia. Actually, it's like myopiology, or a science which deals with going into the depth about how myopia progresses and what all treatment options we have. We have just covered optical interventions, and my topic will be on pharmacological interventions in myopia. Actually, last year I attended the WSPOS at Milan, and as Rohit sir had suggested, there is a school of thought that you don't need to treat myopia. Let it progress. After some time, it will stabilize, and then you can treat it with some refractive correction as well. But there are associated risk of ophthalmic complications, and many of these are visually blinding. Dependency on glasses makes the child visually handicapped without glasses as such, especially the higher power glasses. Financial burden because of change of glasses or contact lenses, and potential surgical interventions in terms of complications related. And a psychological impact, that is a high index glass does induce some amount of low self-esteem in the child. So when we are considering treatment for myopia control strategy, we need to understand that there should be a strong clinical data to support the effectiveness and established treatment protocol. It should be cost effective, because I think optical or DIMS glasses are not cost effective as such. It should be easily available. It should be easily used. I mean, there should be ease of use, minimal or no side effects, because we are going to treat these children for prolonged period of time. There should not be a rebound phenomenon. Once we stop the treatment, there should not be reversal of myopia. Also, there should not be something like a tachyphylaxis, like prolonged period of time, the effect of the drug reduces. There are different treatment modalities for control of myopia suggested, but with time we have realized that low dose atropine and DIMS, they definitely work. Whereas lifestyle modifications and orthokeratology, they might work, but they may not work alone. They might be supplementary treatment to optical or pharmacological treatment which we have. So coming to low dose atropine, it is the most commonly used method for myopia control all over the world, because there is a data from large multicenter randomized clinical trials, especially ATOM-1, ATOM-2 and LAMP study. It is in India, it is available as 0.01% atropine sulfate. And to tell you in short, diluted atropine has actually revolutionized the treatment of myopia control. The advantages of using low dose atropine is that there is a strong clinical data. I will be sharing a few points from that. It is availability and cost is not a problem, and ease of use. You have to simply apply one drop, but as Rohit sir suggested, for prolonged period of time like 2 years, it may not be a great idea, or it's not that easy. The problem or disadvantages with atropine is for higher concentration of atropine, like photophobia, a rebound phenomenon. Also, all the clinical data is till 14 or 15 years of age. We don't know how atropine works beyond that, but it can be used, and there are no side effects using after that. The mechanism of action are proposed to be one of the three, or a combination of three. One is that atropine causes release of dopamine in extracellular matrix and vitreous, thereby inhibiting retinal signaling process, and which in turn leads to inhibition of axial elongation. Also, it is believed that atropine causes release of extracellular matrix by the scleral fibroblast and directly inhibits the axial elongation. The third theory is that atropine reduces the extracellular matrix at the choroidal level, thereby increasing choroidal perfusion and choroidal thickness, which in turn leads to inhibition of axial elongation. Whatever the mechanism be, one thing is for sure, that the routine or the well-known muscarinic effect of atropine perhaps, or the effect of atropine on accommodation, does not have a role in myopia control. There are 3 studies which have been done so far for the use of atropine. The first one among them was ATOM-1. ATOM-1 was started somewhere in 2007-8 to find out the role of 1% atropine sulfate, which was commercially available in control of myopia, versus placebo, and they basically studied it for 3 years, out of which 2 years was the treatment part, and 1 year was the washout period when the drug was not given. And at the end of 3 years, they found that yes, definitely atropine does arrest the myopia progression, but obviously 1% atropine cannot be used commercially. So they studied the other concentrations of the lower dose concentrations of atropine in atom study. And they found, again they divided into 2 years of treatment phase and 1 year of washout phase. At the end of 2-year treatment phase, they found that 0.5% atropine actually performed better than the other two, including 0.01%, which we use. However, after 1 year of washout phase, they found that the axial elongation was more with 0.5% atropine compared to 0.01% atropine. Also, progression of myopia was more in 0.5%. So at the end of 3 years, overall, the progression was minimal with 0.01% atropine compared to the higher concentrations which were used. The LAMP study was to investigate the efficacy of low dose atropine, the 0.05%, 0.025%, and 0.01%. The study is still being done. What results they have found is that if you compare the treatment versus side effect ratio, it is best with 0.05%. In terms of spherical equivalent refractive change and axial elongation, 0.05% is better than the other two concentrations of atropine. However, there are some unanswered questions. One is that we don't know about the rebound phenomenon once we stop atropine 0.05%. Also, we don't know whether 0.05% works better in the second year of treatment compared to 0.01%. And also, we don't know if there is a rebound phenomenon, which will be the best concentration of atropine which we can use. So, a meta-analysis by Huang et al. Have suggested that as of now, 0.01%, this was in 2019, I think, 0.01% atropine is still the best pharmacological treatment available for treatment of myopia, at least to start with, because of minimal side effects and least chances of rebound phenomenon. So there are certain limitations of atom and LAMP study, and the most important limitation is that all these were done in East Asian ethnicities, China, Japan, all those areas. So there have been studies in other ethnicities also before we extrapolate their data or the data of these studies to other ethnicities, and in India also. And all these studies have found that yes, atropine can be used, or whatever the data we got from atom and LAMP study can be used in other ethnicities as well. There are, so how the treatment for or recommended treatment for atropine, different groups have given different kind of treatment, but basically this is the crux of all of them. Atropine sulfate 0.01% is what we use commercially. Dosage is once at bedtime, and whom to recommend, usually between 5 to 14 years. It can be used till 16 years, even I am using that. Usually it is given for simple myopia. It is not given for myopia with ROP or index myopia. And also, we don't start immediately in the first visit, as sir had already mentioned or already been discussed. So when you see a patient of myopia, we need to confirm that there is a progression of myopia. Usually, if the increase of myopia is more than 0.5 diopters at end of 1 year, then we need to start the treatment. It can be lower cutoffs for patients who are more prone to have a myopia progression, like family history of myopia. So how long to continue the treatment? Even WHO recommends that at least for 2 years, you first follow up the patient at 2 to 3 months to see the compliance, and then every 6 monthly. Cycloplegic refraction has to be done at every 6 monthly to confirm the progression. Axial length may not be done according to certain recommendations. And when to stop the treatment? The treatment needs to be stopped if there is no progression of myopia at the end of 2 years, or if it is less than 50% of what we started with, and there is no need to taper the drug, we simply need to stop it. If there is, for patients who are non-responsive, as we have already discussed, you can start, low dose atropine can be given along with optical treatment like DIMS glasses. A word about pyrenzepine, because this presentation is on pharmacological intervention, though we are not using it, but there is, the basic reason why pyrenzepine went into disrepute was because it has poor ocular bioavailability, and there is an anecdotal report of ion-based ophthalmic delivery system of pyrenzepine, which will be something like a sustained release preparation in the eye to control myopia. So to conclude, low dose atropine 0.01% is a well-established treatment for myopia progression, especially in simple myopia. It is relatively cheap, easily available, and basically you have strong clinical data, not only to suggest its use, but also recommendations on how to use the drug. and it can be used along with other optical treatment in cases of non-responders. There are a lot of references which we can go through. These are only the references which I found relevant for my presentation. Thank you.
Thank you, sir. Thank you for compiling all that we know about